Hi, this is the second video on prostate problems. In the first video, we discussed acute and chronic prostatitis. In this video, we will discuss benign prostatic hyperplasia and prostate cancer. The older a male gets, the higher is the likelihood that a male will be faced with symptoms of benign prostatic hyperplasia. This is also called BPH. BPH is present in most males over the age of 60. And it tends to become significant as a male approaches the age of 70. The symptoms are urinary frequency, urinary urgency, urinary hesitancy or slow urine flow, interrupted urine flow, terminal dribbling, acute retention of urine, and nocturia, or the need to get up and urinate multiple times during the night. A rectal exam will show an enlarged prostate. The physician will normally investigate by ordering a urine culture, renal function test, prostate-specific antigen levels, post-voiding urine residual ultrasound to confirm that bladder obstruction and urine retention has not reached damaging levels. A needle biopsy of the prostate may also be performed if the physician suspects carcinoma of the prostate. Some physicians prefer an MRI of the prostate with and without contrast material if they suspect carcinoma. We will discuss the choice of an MRI in more detail later in the video. Treatment should be directed to reduce urethral resistance to urine flow and to minimize any damage to the detrusor muscle, which is responsible for the contraction of the bladder and the expulsion of urine from the bladder. Medications can be used to increase urine flow, but these are not nearly as effective as surgery. The most effective long-term treatment for obstruction is transurethral resection of the prostate, also called TURP, T-U-R-P. Indications for surgery are deterioration of renal function, upper urinary tract dilatation, and urinary retention. Let's discuss carcinoma of the prostate now. Prostate cancer is the second leading cause of cancer in men in the United States. The first is lung cancer. About 1 in 41 men will die of prostate cancer. It does not normally present before the age of 50 and is very common by the age of 80. This does not mean that all men over 80 have an aggressive form of prostate cancer. Although prostate cancer may be present in the prostate tissue, most tend to be dormant. Prostate cancer is normally asymptomatic initially, even when it extends beyond the prostate. It usually starts in the posterior portion of the prostate. Screening for prostate cancer is important. Cancer screening means looking for cancer before it causes symptoms. The goal of screening for prostate cancer is to find cancers that may be at high risk for spreading, if not treated, and to find them early before they spread. Screening for prostate cancer begins with a blood test called a prostate-specific antigen level, a PSA level. This test measures the level of PSA in the blood. PSA is a substance made by the prostate. The levels of PSA in the blood can be higher in men who have prostate cancer. The PSA level may also be elevated in other conditions that affect the prostate. Your doctor is the best person to interpret your PSA test results. Clinical features of prostate cancer can be bladder outflow problems, acute urine retention, back pain, hip pain, blood in the urine, weight loss, perineal pain, and fatigue. A rectal exam may find a nodule. If the disease is advanced, the prostate may be hard and irregular. But there may also be no indication of a tumor on the rectal exam. If the PSA is elevated, the physician has options. One option is watchful waiting and repeat PSA levels. Another option is a transrectal biopsy of the prostate. Another option is an MRI of the prostate. An MRI of the prostate may be the best choice. Again, prostate cancer is the second leading cause of death in men worldwide. Increases in PSA levels during screening are responsible for the detection of cancers. These cancers have a high likelihood of being indolent and show lower grade and lower volume upon presentation. This has historically resulted in the overdiagnosis of clinically insignificant cancer that would not have resulted in significant symptoms or cancer-related death. The risk of overdiagnosis is overtreatment. Overtreatment often results in significant side effects. Active surveillance has therefore emerged to address this problem and is now the recommended management strategy of choice. Active surveillance helps eliminate the risk of underestimating the extent of cancer that can result in missing the opportunity for a cure. Transrectal biopsy randomly samples 1% of the prostate gland and is therefore prone to sampling error. Transrectal biopsy underestimates prostate cancer aggressiveness in about 1/3 of the cases and may miss 30 to 40% of clinically significant prostate tumors. MRI of the prostate has been shown to detect prostate cancer. It can identify previous misclassifications of cancer. It produces better location and staging, and whole gland imaging is much better for identifying anterior disease. This is important because anterior disease is not palpable on rectal exam and usually missed by biopsy. MRI images would also show whether a cancer has spread outside the prostate gland or not. This can have a very important impact on whether or not an individual gets treatment, and if so, which type of treatment would be appropriate. So an MRI is the investigative test of choice. In my experience, insurance companies usually give patients a hard time when an MRI is ordered for surveillance of prostate cancer. You should work with your doctor and demand that the MRI be authorized by the insurer. It may take effort, but don't give up until the insurer agrees to the MRI. Well, I hope this helps. Have a good day.